Good evening, everyone, and welcome to Pull Up with Limbs and Things. My name is Dr. Chanel James, and I'm the owner of Limbs and Things mobile and telehealth physical therapy practice. Our goal is to help you move from I can't to I can. And on this episode of Pull Up with Limbs and Things, we're talking to Dr. Alexandra Hill, and she is the founder and owner of Pelvic PT. And we met on Instagram. This is the place to meet people now.
Yes, it is.
And I am so glad to have her here because all of her content is specifically about those topics. And she talks a lot about how we can address it even as we're getting older and how we may be considered, mm, in a way, like we're too old to talk about something, but we're not. So
Nope.
tonight we're talking about age bias in cancer specifically and pelvic health concerns. So welcome, Dr. Alex. How are you?
I'm good. Thank you so much for having me on.
Absolutely. So tell us a little bit about you and how you started to get into this specific niche of physical therapy.
Yeah, so I've been a physical therapist for 12 years now, this month, which is crazy. I went to PT school at University of Florida, so go Gators, get my little Gator chomp in there. And that's where I first found out about pelvic health and oncology and kind of that intersection. And so I immediately fell in love with it, the impact that you could have within a single visit of just educating, empowering, which is why I'm so excited to be on today. And so that led me to then do a women's health or pelvic and women's health residency
Mhm.
at Duke University in North Carolina. And so ever since then, I've just specialized in pelvic health and oncology. I've made my way back south again. So I currently live in Jacksonville, Florida. And I just opened up my own practice last year, last fall.
Congratulations.
I've
Yeah.
thank you very much. I have my
Mhm.
own clinic here in Jacksonville. I do telehealth. So it's been really exciting. And like you said, we met on Instagram, and my company, Pelvic PT, I started it in 2020 when it was just the height of insanity, really. I
Yeah.
mean, it was
Yeah.
misinformation, disinformation. It
Mhm.
was just, there was so much going on. And so I wanted to have a way to put out some goodness into the world in my little corner of the internet and some good information that people could trust, because this are scary things to think about and talk about, of pelvic health and some of these symptoms and oncology and navigating this. And so I wanted to be a good voice out there for people. And so that's really where the company started, was doing Instagram posts, and then it's now been built to YouTube videos and courses for clinicians. And so it's
Yeah.
been a fun ride the last 5 years for Oncopelvic and 12 years as a PT.
Awesome. Well, I'm glad to hear that. Tell us a little bit about why age bias is a concern in these areas of PT.
So I'll start first with pelvic health. And I
Okay.
think a lot of times people, especially women, but everybody, really just think that some of these symptoms are normal. And
Mhm.
that could be especially leakage, so urinary leakage, or
Mhm.
constipation, pelvic pain, prolapse, where the organs start to drop down into the vaginal area.
Mhm.
Um, and people just think that that's normal, or they can't do anything about it. And especially as people get older, sometimes concerns can get brushed aside, or maybe there's other concerns that they have. And so oftentimes they're not addressed,
Yeah.
and the providers might not be asking about it, and patients may be uncomfortable asking about it or talking about it. These are hard things to talk about. They can be embarrassing.
Right.
And so again, like, they're just not talked about, or their provider, unfortunately, I'm still hearing this, says, oh, just put on a diaper.
Mm.
We are in 2026. That is not the answer anymore.
That's the answer. Exactly. Yeah.
And that's on kind of the pelvic side of just, the assumption that as we age, it's inevitable that these things will happen and we can't do anything about it. On the oncology side, I think it's really in terms of the age bias of, oh, there's a cancer diagnosis, we can't optimize function with this diagnosis or with this treatment. It's just kind of, okay, let's just get through treatment and see how you do. Versus what we know in the research of, like, let's do prehab, like, let's get you stronger, let's get you more active before and during your cancer treatment.
Mhm.
and not just brushing things under the rug or hoping that you get through it okay, when we know that these things are helpful for people to get through their cancer treatment and their cancer diagnosis. And I think a lot of times too, especially in, when we talk about kind of the aging bias, is it can be difficult to get a cancer diagnosis sometimes, especially in, the pelvic area, because there can be other things that are going on. So there could be, for example, polypharmacy. So as we get older, oftentimes we see, a long list of medications.
Oh, yes.
But could that constipation be from the medications, or could that
Yeah.
constipation also be maybe a sign of colorectal cancer? So, these things, these symptoms that, again, as people get older, that they just kind of assume are normal, or that their provider just kind of like, oh yeah, just take some laxatives, instead of really questioning and diving down into it. I think that's where we get into trouble with kind of that age bias in both of these populations.
Hmm. Let's take a little time on the laxative part. I find that
Yes.
there are a lot of aging adults, especially those who are either in facilities or they live at
Mhm.
home, and they're having a period of time where they feel like, okay, I should have gone at least this many times in this period of time. And so they
Mhm.
decide, okay, I need to take an enema or I need to take a laxative. What are the dangers of doing that?
Yes. So first, what is normal? So normal is
Mhm.
3 bowel movements per day to 3 bowel movements per week. So if
For
you're
a range.
outside of those ranges, right? If you're going 5, 6, 7, 8 times a day, or if you're going once or twice a week, then
Mhm.
definitely bring that up to your provider, or if those bowel habits have changed. But if you miss a day or two, and that's normal for you, that's generally okay. But in terms of those laxatives, especially the ones that are stimulants, so like Senecot, or Senna, a lot of people like the Smooth Move tea just because it tastes good, it's a tea, it's easy.
Mhm.
These stimulants, they act by irritating the colon. And so over time, they get less effective, and they can also cause more urgency and can potentially lead to more issues like fecal incontinence.
Mm.
And so we want to be mindful of, one, the types of laxatives that we're using. So a stimulant versus, for example, an osmotic, meaning it's bringing water into the colon, into the stool to soften it. That would be something like a Miralax, for example. Those are generally better tolerated. They're not necessarily dependent. There's been studies that they've been, used for really long periods of time. Those are generally a bit better, more recommended versus the stimulants. But again, we want to figure out why people are having that constipation first to really get them the appropriate treatment.
Absolutely. So, who would be the best provider for them to see?
For the constipation, I would recommend a gastroenterologist, so
Yeah.
a doctor who specializes in the gut, and then
Hmm.
a pelvic health therapist.
Exactly. And I think a lot of people know, okay, what doctor to go to, perhaps.
Yeah.
But then they don't consider like physical therapists can help you with this aspect. So
Mm-hmm.
let's talk about what you would do for someone who possibly has this constipation issue and they're trying to figure out, okay, if I go to a pelvic health therapist, okay, what's going to happen? Are they going
What
to
do we do?
be
Yeah.
invasive?
Right? Like, how do you help me poop?
Yes, exactly.
So, the first thing is we get a very thorough subjective. So, we ask a lot of questions. So, how long has this been going on? Is this lifelong, or is this newer as you've been getting older with the medication? How often are you going? Do you have pain? Do you have bleeding? Do you have to use laxatives or enemas? So, we ask a lot of questions. And
Mhm.
again, it can be embarrassing, but the more you tell us, the better we can help you. And frankly, like, there's nothing that is TMI in pelvic physical therapy. Like, there is nothing that is TMI.
Uh-huh.
So we ask a lot of questions first, and then depending on what we find with what your symptoms are, then we'll do a modified pelvic exam. So typically for constipation, that would mean a rectal exam, but it's not like an exam that you would get with a gastroenterologist or with a physician. We're looking more at those muscles and even the sensation of the rectum to
Hmm.
really determine where is that issue coming from. So if we look at constipation, it could be more of a transit issue. So maybe your colon's just sluggish, or it
Hmm.
could be an outlet issue. So the pelvic floor muscles aren't opening like they should to let that stool out. So we can help with both, but especially if it's like you're straining, you're pushing, and it's just not going, that's where pelvic physical therapy can really be helpful, and doing that exam can be helpful. Now, that being said, if you're not comfortable doing the exam that first visit, or ever, I have a lot of patients that just, I don't want a finger in my rectum, and that's
Yeah.
okay, right?
Yeah.
You always have the option. There's a lot of other ways that we can still assess the pelvic floor externally. I've had some people where we even do it over clothes. Again, I do this via telehealth as well. Doing the exam is going to give us the most information, but again, we tailor it to what the patient is comfortable doing. And then based on what we find on that exam, so how are your muscles working? What's your sensation? And then we'll get you started on, of course, homework. What's PT without homework, right?
Exactly.
So that could be dietary changes. So
Mm-hmm.
maybe changing your laxative, definitely increasing your water, increasing your fiber slowly, moving more helps to get the gut going. And then that could also include maybe some stretches or exercises, and then pelvic floor exercises. But pelvic floor exercises aren't always Kegels. So people think of pelvic PT and like strengthen, strengthen, Kegel,
Yeah.
Kegel, squeeze,
Yeah.
squeeze, these.
Mm-hmm.
But oftentimes with constipation, we need to work on a reverse Kegel. So relaxing the pelvic floor and getting better coordination. So it's usually what's recommended with this population.
Well, that's good because I've seen patients and they'll say, "Well, I've been working on my Kegels and I'm doing a great job there." But I was like, "So what if that's not the
Yeah.
issue? What if you don't need to
Right.
strengthen?" So
Right.
there are a lot of people who definitely think Kegels are the only way to go, and
Yes.
they really need the evaluation to know, is it really a strengthening thing or do you really need to relax? So
Yes. Yep. Or a combination of both, maybe. Because
yeah.
oftentimes, as you know, a tight muscle can be a weak muscle. So we
Yep.
need to make sure as we start to get things more coordinated that then you're able to control that stool as well.
Absolutely true. So, what do you think is the best way for an aging adult to advocate for themselves if they say, they always are at the doctor, maybe
Mhm.
not the gastroenterologist? So, if they're at their primary care, maybe what's something they can do to advocate for themselves to get to the right person?
I think first is going in. I think it's easy, especially with how short the visits are nowadays with our providers.
Hmm.
Things just get lost. And so I think coming in with a list of your symptoms written out, or even writing out like constipation, pelvic PT referral, like even just having that reminder,
Yeah.
and saying, hey, I'm having this issue. I listened to this amazing podcast. I saw, I learned about what pelvic PT is. Is this
Yeah.
something that you think would be helpful?
Hmm.
Most of the time, they're not going to say no. They may not fully understand, unfortunately, everything that we do in pelvic PT. But at the end of the day, your providers want to help you.
Yeah.
And so, especially if they have a relationship with any of the pelvic PTs in their area,
Hmm.
getting that referral, and really, like you said, advocating for yourself and speaking up for yourself, that like how we open this conversation up, like these are things that are not, you don't have to deal with them.
Yeah.
So advocating for yourself to really get the treatment that you need and that you deserve, is going to be helpful.
Absolutely. Okay, let's do the transition between pelvic health and oncology because you
Mm-hmm.
can have both going at the same time in the same
Mm-hmm.
person. So
Yep.
tell us a little bit about how they overlap.
Yeah, absolutely. So you can think of it kind of two separate buckets. So one is people who have pelvic cancers. So that is definitely impacting pelvic health and oncology. So bladder cancer, prostate cancer, gynecologic cancer, colorectal cancer, those are all impacting those pelvic organs. But you can also have pelvic health dysfunction or pelvic floor dysfunction related to cancers that are outside the pelvis. So the most common one would be breast cancer. And so
Yeah.
if somebody has breast cancer, oftentimes they, if it's a hormone dependent, so estrogen dependent or progesterone dependent breast cancer, they'll have some type of hormone therapy. And so that can then lead to menopause, which
Mm-hmm.
will then lead to vaginal dryness. It can lead to bladder dysfunction, sexual dysfunction. And so these cancers that are outside of the pelvis, especially these systemic treatments like hormone therapy, chemotherapy, we're finding also now with targeted and immunotherapy that these can all also impact the pelvic health as well. So even chemotherapy, notorious for causing GI distress or diarrhea. If
Right.
somebody has underlying pelvic floor issues, like a weak pelvic floor, and now they have urgency, they have frequency with these bowel movements, and they can't control it, now we've got an issue of needing to manage those bowel symptoms as well. So that's kind of how I like to think about it in terms of how they overlap, is those, again,
Mhm.
specific pelvic cancers or cancers outside the pelvis, but are also having especially again, those systemic effects impacting pelvic health.
That was a great way to describe it too, because that's what I wanted you to say. There are so many other cancers where you have the overlap of having your pelvis involved in
Mm-hmm.
how you're treated, and how you're having to figure out, okay, this is now different. Something's different about what's
Yeah.
happening to me. And a lot of times I think we think if it's different, it's supposed to just happen that way. If something else is going on, but we don't pay attention to the other
Right.
things that are happening. So
Right.
tell us a
Right.
little bit about what you wish more oncology providers discuss with patients before treatment starts.
I'm going to get on a soapbox here, and I will just say umbrella.
Okay.
Refer early and often.
Hmm.
We are finding, again, in the research, more and more support for prehab across virtually all cancers, all treatments, and the benefits of prehab. So, what that means is essentially at the time of diagnosis, it's a flurry of referrals. You're getting then referred to radiation oncology, getting referred to gynecology, getting all these extra referrals, but oftentimes rehab is missed, or it's an afterthought, or
Hmm.
they're referred after treatment has started or after they're already having issues.
Right.
Versus you get the diagnosis, you get referred to, we'll say PT, and we do baseline measurements. So we understand what your strength is, your endurance. Maybe we'll do a pelvic exam depending on what your cancer diagnosis is or your treatment. We'll do circumferential measurements. So we'll measure your
Yeah.
arm or your legs if to assess for lymphedema. And we give a lot of education. So things like energy pacing, conservation, safety tips, exercises to start with. So even if it's just one visit to get the baseline measures and some tips to get started with treatment,
Hmm.
prehab can be so effective for patients. So I think that would be the number one thing that I would say.
Yeah. That's great. I think that it's important that we know that these things exist, not
Hmm.
just from the patient perspective, but definitely the provider perspective too.
Yeah.
Let's see. What are some symptoms you found that patients are embarrassed to talk about or they absolutely should not ignore?
Um, I think any significant and sudden changes, or even if they're gradual changes, but changes in bladder and bowel function.
Okay.
So things with your bowel movements, if you're having excessive bleeding, if your stool's getting harder to pass, if you're noticing that your stool's getting very thin, like the size of your pinky or a pencil, um, those would be some things to be looking out for.
What about color?
Difficulty. Yeah, colors also, if it gets really dark,
Hmm.
that can be a concern. So like kind of a black tarry color, um, bladder issues. So those would be things to definitely talk with your provider about. It could be nothing, right? Blood in your urine, it could just be a UTI. Those are very common, but that could also be the sign of something else going on as well. So
Hmm.
anytime that you have a change and it's persistent,
Okay.
that's a time to talk with the doctor for sure. I think some things that people are especially embarrassed about asking is pain with intimacy,
Yeah.
for sure. So sexual health, and that could be for a lot of different reasons. But that pain, again, it could be as simple as you have vaginal dryness because now you're menopausal, and that's as easy to fix as using maybe some topical vaginal estrogen or a moisturizer, or that could be the sign of, especially with deeper penetration, that there's something going on deeper, so like a gynecologic cancer. So, there's a lot of different things that could be going on, but any of those types of changes, it's worth asking your provider about. And again, it can be embarrassing to talk about, but if you have that piece of paper, or when you schedule your appointment, especially if it's like in the portal, to just type it out. Sometimes typing it out is a
Good
little bit
idea.
easier than saying it out loud.
Sure.
Sometimes having a support person, so your partner being with you, can be helpful as well. But I think the biggest thing with these is if you notice any bladder bowel changes, especially, or something just doesn't quite feel right. You could have just abdominal bloating or discomfort that just does not go away no matter what you do. That could even be a sign of something else that needs to be looked at as well. So just talk with your provider. It's always better to bring it up, and it's something that's, not an issue, versus waiting. And then now if it is cancer, now it's then developed into a more advanced stage. So always ask about it.
Absolutely. Okay, so this one I think is a little different because we are physical therapists. We tend to think certain things are normal. But what would you say to a physical therapist or healthcare providers that we should stop normalizing in older adults?
That we should stop normalizing. I would say the bladder and bowel symptoms. Again, like I know we keep coming back, but it's so common. With the, especially constipation, our gut typically just slows down a little bit more as we get older, but there's also other things that we need to be looking at as well. Is it also, like I mentioned earlier, a lot of medications? Is it potentially cancer? Is it depression? There's so many things that could be contributing to it. To just brush it off as, oh, you're 60, time for constipation. Like, that's not a thing. Like,
that is not a thing.
Or like 65 Medicare constipation. Like, that doesn't come with the package. Like,
what about those people who are feeling like at night I go more often?
Absolutely. Yeah.
Some of the things that are disruptive to sleep.
Yeah. And that's a really great point to bring up. So for those under 65, getting up 0 to 1 time per night is normal. Over the age of 65, okay. Up to, are you thinking about how your sleeping habits are?
Yeah.
So if you are over 65, then getting up to twice a night is considered normal.
Up to twice. Got it.
And so if you're needing to get up 3, 4, 5, 6, 7, 8, 9, 10 times a night, you're not sleeping through the night, definitely something to talk with your provider about. That could be, again, from a lot of different things, everything from if your ankles and your feet swell during the day, and you're not wearing compression socks, right? You put your feet up at the end of the day, what happens to that fluid? It gets all the way back into the body, it gets filtered through, and then you're having to go. Yeah. It could be, again, from medications. If you're taking, say, a blood pressure medication, like a water pill,
right?
If you take it at night, you're going to have to go more, right? So sometimes it's like maybe talking to your provider about changing the timing of your medications. It could be something of just the bladder is just getting in a bad habit. So especially for people who are maybe getting up the same time every night. So they get up at 11 p.m., they get up at 1 a.m., they get up at 3 a.m., and they know, like, it's like clockwork. That's actually usually a little bit easier to address, especially with pelvic PT, because we just need to retrain the bladder. At this point, it's just, again, like on a bad habit cycle of, oh, okay, 11 p.m., time to go. Ding-a-ling-a-ling. No, we need to tame that bladder and tell it who's boss. Yeah. But if you do notice that it's a change of maybe you're getting up once or twice a night, and now you're getting up more often, again, that's something to talk about with your doctor.
Thank you for sharing that. I find that there are people who are doing 3 to 4 times a night and not getting sleep at all. So
yeah. Well, and also you look at, having to get up at nighttime. Nighttime's typically dark, right? A lot of falls
falling down.
Exactly. Yep. So if you're having to get up multiple times a night, you're rushing to the bathroom so you don't pee your pants. Or even if you do have a leak on the way to the bathroom, then there's the potential for slipping.
Yep.
right? So the more that we can address getting up at nighttime, the better.
Absolutely. Okay, so let's go back to oncology. What would you
Mhm.
consider is truly patient centered rehab in oncology?
Always focus on what the patient's goals are. And it's not a matter of, um, on the rehab side, just checking a box of like, what are your goals? Like, it's really understanding like what brings you joy.
Yeah.
And especially with oncology and the aging population, it can be hard to find some joys with just dealing with the side effects of chemo and then radiation, and then you're dealing with the fatigue and the pain, and it can get very heavy. And so I think if we really look at patient-centered care in general, but especially with this population, really working on those goals for things that are going to help to bring them joy. So if they love gardening, but they
Mm-hmm.
have pain or they leak every time they try to bend down to garden, let's work on that. Let's work on those things to get you back to having that joy. And it might be just stepwise working on things. But again, for me, I think that's the biggest thing is goals that bring joy. We'll
I
sum
like
that
it.
up.
So I had an aunt. She was 93 when she passed away
Mm,
last year. She was diagnosed
I'm
with breast
sorry.
cancer. Thank you.
Mm,
And it was a later diagnosis. Do you find that
yeah.
older adults get diagnosed later in life?
Later in life, in terms of a later stage diagnosis,
Age. So,
age.
like 80s versus someone who's a little younger. I find that when people are older, they tend to think that the cancer is slower growing and it won't
Mm,
be as much, I guess, aggressive therapy treatments.
yeah.
So, what's been your experience?
That's a good question. Um, I honestly would say it kind of varies. I have some patients who are just so hyper vigilant on their health, and others
Mhm.
who, again, say they might have the mindset of, well, they're not going to do treatment anyway, or
Mhm.
they've been told you're, I'm saying this in quotes, too old to have surgery,
Yeah,
right? Because there are risks with getting surgery, and so I do find that some patients just don't maybe bring it up or don't want to deal with it because maybe a fear of that there isn't going to be treatment that's available for them, or they just don't want to deal with it anyway.
right.
Because again, the side effects from some of these cancer treatments are rough
Yeah.
at a young age, let alone in your 80s and your 90s as well. So I think I would probably agree with you, though. I think on the flip side, we are seeing in the research a lot more younger patients that are getting diagnosed at younger ages. So, like, especially
True.
colorectal cancer.
Hmm.
I treated a patient, she was in her early 20s with colorectal cancer.
Wow.
So I think on these extremes,
Hmm.
it's where we're missing a lot of folks, and they're kind of falling through the cracks. It's kind of like between 40 and 70, like that's the prime time that you're getting the screenings, you're getting
Right, right.
questioned, like,
So you
and then
get
if you're
age
outside
bias
that
on the front
range,
end and the lower end.
yup.
Gotcha.
Ugh, we got
Hmm.
to do better.
We got to do better. Exactly. So I want to thank you so much for sharing all of your knowledge. Please let us know if you have a final thought in anything we've discussed or anything we haven't that you would like for older adults or someone who's working with them to know about oncology and pelvic health concerns and physical therapy.
I think number one, don't accept that getting older automatically comes with all of these issues that you cannot treat.
Hmm.
These are absolutely treatable. Again, the bladder, bowel, pelvic pain, prolapse, sexual dysfunction. Those are all things that we can treat. It's never too late. I've worked with people who have had, especially leakage for, I think their record was like 50 years, and we got it down, right? So it's a
Oh,
matter
okay.
of recognizing and that you have these symptoms, and then advocating for yourself, even if it is scary.
Yeah.
But what's worse, dealing with this or saying it and getting an uncomfortable appointment out of the way and then feeling better. So I think that's really the biggest thing. And if you are a recently diagnosed with cancer, you have a family member or a friend who has cancer, advocate for rehab. Especially if they're at a larger hospital institution, rehab should
Mhm.
be integrated with their oncology team. Um, just advocate, 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 push for it. In all 50 states, we have some form of direct access, meaning you don't need a referral for physical
Right.
therapy. Some hospital systems still do require a referral, but either way, just advocate for that rehab because there is power in PT.
Absolutely. How can we connect with you?
You can find me on all my social media channels at Oncopelvic PTs. So Instagram, Facebook, YouTube. I have a blog on my website, and then email just hello at Oncopelvic PT if you need help just finding somebody near you or getting you connected with somebody.
Well, I so appreciate your time. And it's so wonderful
Absolutely.
to meet
Thank
you
you.
in virtual person.
Yes, absolutely. Thank you so much.
Absolutely. Thank you for coming. Everyone have a wonderful evening. Remember, pull up with limbs and things is to confirm something you know, challenge something you don't know, and give you the opportunity to share this information with someone else. So please do that. Have a good night.